In this video, we will cover two related but distinct situations. The first is removal of a loose corneal suture. The second is removal of a corneal suture that is not loose, but has reached the point where we'd normally remove it electively. A loose suture should be removed urgently. It causes discomfort, it is no longer contributing meaningfully to wound strength, and it becomes a significant risk factor for infection. In graft cases, there is also a theoretical concern that loose sutures may contribute to vascularization and may potentially trigger graft rejection. It is sometimes the case that clinicians see a loose suture and leave it in place, but that is a mistake. Loose or broken corneal sutures should be removed when they are first identified. By contrast, a suture that is not loose may be removed electively once the wound is judged to be secure enough. In order to prevent later suture-related complications such as loosening, breakage, irritation, or infection, corneal tissue heals slowly and sutures are often left in place for many months until the eye is considered ready. Typical scenarios include cataract wound sutures, sutures after corneal trauma repair, and sutures after penetrating keratoplasty. Patients with a loose suture often report irritation, discomfort, watering, or foreign body sensation. On examination, there are several useful signs. First, the suture may be elevated above the corneal surface. Second, there may be mucus collecting around or beneath the suture. Third, there may be fluorescein staining at the epithelial entry points of the suture. This likely reflects epithelial disruption from micromovement of the suture, together with fluorescein tracking at the entry sites. Before removing any corneal suture, explain clearly to the patient what you are going to do. Reassure them that it should not cause significant pain, but that they must look exactly where you ask them to look and keep as still as possible. You should verbally consent for the small risk of infection, although you can, of course, state that the removal of the suture reduces the long-term risk of infection. For post-trauma and penetrating keratoplasty, you should consent for dehiscence of the wound and a need to return to theatre that day to put a further suture in. Next, instill topical anaesthetic, such as proximeticaine, and allow the initial stinging to settle. Once the stinging has settled, this suggests the corneal surface is adequately anesthetized and povidone iodine can then be applied. In some cases, particularly where there is crusting of the lashes or lid margin, povidone can also be applied to clean the lashes and periocular skin, although the aim should still be that instruments do not touch the eyelashes. Povidone iodine is essential because it reduces the risk of dragging surface bacteria into the cornea or even into the anterior chamber in a full thickness wound, and this could cause endophthalmitis. The intended technique should be non-touch, with instruments contacting only the ocular surface where required. If an instrument inadvertently touches the lashes or an unprepared lid margin, its sterility has to be reconsidered before continuing. I do not usually use a speculum for suture removal. Instead, I elevate the upper lid manually with my thumb as needed and ask the patient to look in the direction that gives the safest and most convenient approach. That is an important practical point. You do not always need to move your hand to achieve the right angle. Very often, it is easier and safer to change the position of the patient's eye. Always rest part of your hand, often the little finger, on a stable part of the patient's face, such as the bridge of the nose or the forehead. If the patient moves, your hand and instrument then move with them. This is critical for safety. For a loose suture, one option is to divide it with Vannis scissors. If there is enough space, this is often an elegant technique because it avoids transmitting traction into the surrounding corneal stroma. Once the suture is divided, it can be removed with a brisk but controlled movement. Where possible, avoid dragging and not across the wound. For elective removal of suture that is not loose, I prefer to use a green needle, a 27 gauge needle. I use it in two ways. First, as a blade, by rotating it around its long axis so that the sharp edge is used to divide the suture. Second, as a spatula, by using it to elevate the cut ends of the suture. After cutting the suture, I usually lift both ends if possible. This is not always strictly necessary, but it generally reduces resistance and makes the suture easier to remove smoothly. Otherwise, sometimes you can get breakage of the suture at the knot in the deep stroma. Once the ends are elevated, align the forceps in the most natural line of approach, grasp one end, and remove the suture with brisk controlled movement in line with its course, minimizing distortion of the surrounding tissue. After the sutures have been removed, prescribe topical antibiotic drops to the affected eye 4 times a day for 3 days for while the epithelium heals. If the sutures are being removed from a corneal graft, increase the topical steroid frequency for 1 week afterwards, usually double what they were already on, then return to the previous regimen. Suture removal may be a potential trigger for graft rejection, so that extra steroid cover is sensible. So when should a non-loose corneal suture be removed? So for routine cataract surgery, corneal nylon sutures are commonly removed at about 1 month after the surgery. So after endothelial keratoplasty, typically we remove the sutures that are at the side ports and main corneal wound at 1 month. If a DSEK has been done and we've done a scleral tunnel, then suture is covered by conjunctiva, then these do not usually need to be removed. After penetration, keratoplasty sutures are usually left for much longer, and a good general teaching range is that elective removal is staged between about 1 and 2 years. After corneal trauma repair, there is no single timetable. Time depends on the age of the patient, the size and configuration of the wound, and the refractive effect of the sutures. Typically, children heal faster than adults, so the sutures will need to be removed sooner in children compared to adults. In summary, loose sutures should be removed urgently because they cause discomfort, increase the risk of infection, and no longer support the wound. Elective removal of intact sutures is performed once the wound is secure enough to avoid later suture-related problems. Careful explanation to the patient, use of topical anaesthetic and povidone iodine, a non-touch technique in terms of the lashes, a stable hand support, and postoperative antibiotic drops are all essential. Lastly, here's some loose sutures. These were loose for quite a while and kept under a contact lens, and you can see that the consequence of this is that there is now infection in the cornea where the suture goes into the stroma. These should have been removed a lot sooner than it got to this situation.